we're going to switch gears just a bit. I'm going to talk about clinical decision support in big data. And the reason why I'm going to do that, or a number of reasons, but one is I strongly believe that clinical decision support for providers and for patients in big data will significantly improve the value of telehealth when that information is used to interpret information that's ascertained through telehealth technologies for both providers and patients. In the next 10 minutes, I'm going to try to convince you why I believe that. So let's back up a little bit, talk about the American healthcare system. Medical errors are the third leading cause of death in the United States, about 250,000 deaths from medical errors each year, which is more than motor vehicle accidents and breast cancer combined. So it's, according to literature, a significant problem that needs to be solved. So opportunities to improve safety and quality. And then we can't turn on the news, look at the internet, and not read about the unsustainability about rising healthcare costs. And it's been said that 80 to 90% of healthcare costs are directly or indirectly influenced by provider decisions, physicians and other providers. So we're going to talk a little bit about how to get into the provider workflow, whether it's for telehealth or for more traditional types of care, to improve quality and reduce costs. So some additional information. It was said by the Institute of Medicine, now the National Academy of Medicine, when there's a breakthrough, a discovery, a new treatment that'll reduce mortality, reduce morbidity, improve quality of life, there can be a 17-year gap between the discovery and before it is adopted into widespread clinical practice. And how do we shortcut that? How do we accelerate the gap there? There's studies, New England Journal of Medicine, first for adults. For all of us, if we see our doctor, according to study out of RAND, New England Journal of Medicine, we'll receive evidence-based care consistent with the scientific evidence about 50% of the time. Study repeated for kids, pediatrics, New England Journal of Medicine, about 50% of the time. Care consistent with the evidence for telehealth, maybe 50% of the time. Another study, pretty darn interesting, that was published in JAMA recently, that Medicare patients treated by women physicians have lower mortality rates than Medicare patients treated by male physicians. Some of you read that study? It was picked up on the news, right? Actually, my mom went to her doctor, and her doctor said, "Good news, Mrs. Weingarten, you've selected a woman physician, and your chance of dying is lower because of that." And my mom called me to tell me that. Thought that was pretty interesting. And now, why is that? I don't know. There's some speculation in the discussion part of the article that women follow evidence-based medicine principles and approaches more often than men do, male physicians. I don't know whether that's true or not, but my wife pointed out to me, who I did meet on a blind date a gazillion years ago, that before smartphones, she was more likely to ask directions when we were lost than I was. So she might be onto something. About a third of healthcare is waste, meaning the harms exceed the benefits, or there are no benefits, according to studies published in JAMA. About 10% is overtreatment. Harms exceed the benefits. And so during this hour on this segment, if you believe the published data, there'll be about 28 deaths across the United States from medical errors and about $22 million spent on overtreatment. So a great opportunity, whether it's telehealth or more traditional types of care. Information explosion, this is good. This is not a bad thing. 20,000 biomedical journals, 2 million articles each year, 6,000 articles a day, a new scientific article published about every 30 seconds, about 75,000 lab tests. And they said next year in 2020, the doubling time of medical information will be about 73 days. In 1950, the doubling time of medical information was felt to be about 50 years, so 73 days. So for those of you, how many doctors, nurses, providers, you're all really smart and well-trained, but if medical information doubles every 73 days, you can't keep up with that. Cloud's pretty good at keeping up with that kind of pace of information proliferation, but the human brain is just not designed to do that. Great opportunities in information technology. Another article from New England Journal of Medicine, which shows that labor productivity growth has been relatively good in the United States. The U.S. economy, manufacturing, retail trade, with one exception. What is that exception? Healthcare. So we've spent about $36 billion federal subsidies from the American Recovery and Reinvestment Act to subsidize physicians in their office, physicians in hospitals to purchase electronic health records. Telehealth applications, as we've talked about, integrated with electronic health records. Why haven't we had labor productivity growth? So really nice opportunity. Another interesting slide where we really need to leverage existing technologies, telehealth integrated with EHRs. Take a look at the last 40 to 50 years of growth. Physician growth, not much. Administrator growth. Does that surprise anyone here? No. Okay. Again, is there an opportunity for information technology? So I'm going to talk a little bit about clinical decision support, and we'll finish up. But it's really all about system design with EHRs and telehealth inputs into EHRs. So the airlines are pretty good at system design. So if you think about EHRs, the parallel, making it easy to do the right thing, those things that are going to help patients, evidence-based care, and making it harder to do the wrong thing. Now, when I flew to San Jose, I wanted to turn on my reading light. They made it easy for me to do that. I just lifted my hand, pushed the button, and the light went on, which was great. Now, I didn't do this, but when I've been in an emergency exit and we're in flight, if I wanted to open the emergency exit, I'll bet it would be pretty hard to do that. They made it hard to do the wrong thing. Other types of system design. When you go into a restroom, the bathroom, okay, what's the first thing you want to do? It's dark. You want to turn on the light. You turn on the light, it locks the door. Studies show that if you put relevant patient-specific information into the workflow, this would apply to telehealth as well, in a systematic review, meta-regression published in the British Medical Journal, you're 112 times more likely to change care, improve care than if you don't. 112 times more likely. If we think about improving the value of telehealth, a really great opportunity here. Think about outside of healthcare. Self-driving cars. We just had a granddaughter. They tell me that she may never drive a car herself. May all be autonomous vehicles. Think about what Google did and others who are working on self-driving cars. So it's all sensors. All sensors. I mean, a chassis, turn right, turn left, accelerate, brake. We know when a light turns red. We know where all the other cars are. We know when a siren goes off. We know whether the road is wet or icy. We know whether a dog runs into the street. Maybe even when a ball goes into the street where a kid might follow. So this is all decision support outside of healthcare. This is coming rapidly to healthcare. A lot of investment in this area, a lot of people working on it, and I think it'll tremendously improve the value of telehealth. So where is all of this going? Ambient listening devices could be for telehealth applications, could be in the provider waiting room, listening in on the conversations, and then providing guidance to the provider. Mrs. Smith's overdue for a mammogram, needs a hemoglobin A1C. And then for the ambient listening device for the patient. Mrs. Smith would benefit from exercising more, eating a little less fat. So a lot of this is driven by machine learning and AI, providing guidance to physicians and other healthcare providers and patients. And this is only going to get better and better over time. Now, I Googled this. The average 2-year-old apparently has equivalent intelligence to a dog. I don't know whether it's true or not, but that's what Google told me. But let's just go with it for a second. Okay, this dog here, anybody know the kind of dog? Labradoodle. Okay, sharp audience. That's right. So this is a Labradoodle. It's very cute, and this little girl is really cute. They're both extremely cute. This dog may rapidly achieve its full potential in terms of intelligence. This little girl, she could cure cancer one day, become president of the United States. She's got unlimited upside. This dog has limited upside despite how cute it is. Again, with AI and machine learning, as we get smarter and smarter, more data, train the machine learning classifiers, unlimited potential. And this is my last slide, because I know I'm at the end here, that as we think about using telehealth, clinical decision support, and big data, I think of this gentleman. Anybody know who he is? He's a football player. Anybody know the team? Seahawks. Anybody know who he is? How many UCLA football fans out there? I misread the audience. Okay, one, me. Okay, that's my alma mater. So I know, it's a tough year. Okay, your condolences, I appreciate that. So this is Derrick Coleman. And for those of you who don't know Derrick Coleman, he happens to be deaf. And Derrick Coleman, he wanted to try out for his high school football team. And they told him, you can't play football, you're deaf. You can't hear the play called in the huddle, you can't hear the referee whistle the play dead. He's an offensive player, you can't hear the defensive player's footsteps. And he was a star of his high school football team. They said, well, that's one level you can't play in college. And he did play for UCLA, despite everyone telling him he can't play at the college level. And he was really good at UCLA. And they said, that's fine, played in college, whole different level in the NFL. You can't play there. And the Seahawks picked him up. And guess what he's wearing on his ring finger that I'll bet no one in this audience is wearing on their ring finger? Super Bowl ring. And they asked him, they said, Derrick, you're deaf. You've been told your whole life you can't play football. What did you think when everybody told you you can't play football? Now you have a Super Bowl ring. And he smiled and he said, couldn't hear him. couldn't hear him. So I think we're told a lot about how we can transform the American healthcare system, how we can deliver better access through telehealth, improve quality, and improve the affordability by reducing costs. I think we need to listen to all of these concerns, but I believe with all of you and conferences like this, we'll be able to figure out a way to deliver it. I apologize for going over. Do I have time for one question or not? Okay, one question.
Hi, so I'm a physician also, and so evidence-based medicine, of course, we have always used evidence to treat patients. The concept that this is new is kind of silly. I mean, that's how we have evolved from the last, centuries of care. I think the problem that you run into, with creating workflow and creating kind of like, we use all this information and this data and we put it in and we say, okay, here's best practice, is that's public health, it isn't medicine. I think the difference between medicine and public health is public health, you take all that data and you apply it to this whole room and you decide, okay, to get the best result for all these people, we have to treat 50 of these people, but is he 51? Medicine is taking all that data and apply it to that one patient in front of you. So it isn't the electronic plane that can land automatically. It's Sully who can put it in the Hudson when you have to take the controls. That's the difference between medicine and public health, and I think we have to be careful when we use the word evidence-based medicine to assume that we can easily replace the decision-making, because that's the only purpose of having a physician in the equation.
Thank you. You mind if I offer a counterpoint, make it a little bit fun? So the data would suggest, so I believe, yes, physicians trained in evidence-based medicine want to practice evidence-based medicine, but all of the studies show we don't about half the time. Yeah. Published good, high-quality, rigorous studies, New England Journal of Medicine, peer review, so we don't.
But you know why? Because we have to do what the insurance company allows us.
I'm going to disagree for a second. Hope that's okay, makes conferences more fun. So if you believe the doubling of medical information occurs every 73 days, I've always tried to keep up with the literature. Yeah. I'm not that smart. My brain, I cannot absorb new gigabytes of medical information every 73 days. And so the data would suggest no matter how hard we try, and no matter our desire to practice evidence-based medicine, we cannot read and retain the information in all of these articles. There was a study that showed if the physician finished medical school and residency, knew absolutely everything, 100% boards. I don't think there is a physician like that, but let's pretend there is. Read and retained the information in 2 articles every single night, they would be 1,000 years behind the world's medical literature in 1 year. So I think there are factors, as I see it, I don't see this as an insurance company issue. That's me speaking. But I see it more as the human brain cannot keep up with the pace of medical information that's available to all of us to improve care.
I think that there's a lot of information, not all of it is good. And I think there's plenty of studies out there that say that the studies are questionable. Because you look at studies all the time. I read my journals all the time, and you say you pick out who sponsored it, what it's about, what they're trying to show. And we all know that probably about 90% of the data isn't validated beyond what that, even though they're, we see it all the time, and there's been quite a lot of exposures, even at New England Journal of Medicine, where a lot of times articles are not going through the rigor that they should be to be published. So our peer journals have to look at themselves too, because you're right, all this data goes in, and it's exponential, but not all of it's going to be the quality data that we can utilize for our patients every day. I basically think that it isn't that hard to take good care of a patient. It takes focus, and it puts the patient first. I mean, that's all you have to do. We have so many obstacles to care, that 3,000% increase in administration, and then, of course, the concept of having to get paid for things, having to go, follow prescriptions that are actually written by insurance regulators as opposed to what we would do for a patient. I think that is where we're getting derailed, and the cost is going up, and the outcomes are going down because we are not focusing. There's too much distance between the patient and the doctor.
Thank you.
Could I ask a follow-up? So Scott, if you take this doubling every 73 days,
yes,
right, the only logical conclusion is then the AI, that's the only way it will take over. Then what will be the role of a physician within that doubling every 73 days? So
what is the role of the physician? And this is where I agree with the person who asked the question. There's, I believe, tremendous amount of information to inform clinical decision making that I don't know that I would say no physician is aware of. But you have to better understand your patients, their preferences, and a machine, AI, will never replace a physician or other healthcare provider. So the provider needs to be informed by all the available evidence that could save a patient's life, improve their quality of life, and then with the patient and an understanding of the patient's preferences, make the best decision for that patient. You're never going to remove the provider from the equation.
Awesome. Thank you so much.
Thank you.
That was an amazing talk.